On Health Matters, spring is in the air. But along with greening grass and budding flowers comes all that stuff that makes allergies bloom too.
Achoo!
From pets to peanuts, the air we breathe or the food we eat can make us sick. Are allergies becoming more common, or does it just seem that way? Are there new medicines and treatments on the horizon? We ask those questions and more when Health Matters talks allergies. Next. Health Matters is made possible by viewers like you, the friends of KSPS, and by the following.
I really liked the idea of being part of Providence, where if I have a question, if there's something that I'm concerned about, I can always call a specialist. I'm Dr. Anna Barber, and I chose Providence because here I can help children thrive and reach their highest potential.
If you read Providence's mission statement, it's all about delivering quality care to the patient at all times. I'm Dr. Peter Rinaldi, and I chose Providence because they put the doctor-patient relationship first.
Find your doctor online at phc.org.
Health Matters is also brought to you by Hollister Steer Allergy, improving quality of life for allergy sufferers since 1921. Washington State University, Spokane, studying the feasibility of a medical school on the WSU Spokane Health Sciences campus to help solve the primary care physicians crisis in Washington. More at medicine.wsu.edu.
Good evening, I'm your host, Teresa Lukens. Whoever came up with the saying spring is in the air might have been referring to the fact that allergy and asthma sufferers get hit hard this time of year. At least 2 out of every 10 Americans suffer from allergies. So tonight, we're going to talk about the common causes of seasonal allergies, plus how everything from pets to peanuts can potentially cause an allergic reaction. As always, we have assembled a panel of local experts to answer your questions via phone call and email tonight, so let's meet them. Dr. Stephen Kernerman works with adults and children at Spokane Allergy and Asthma Clinic. Dr. Richard Gower is a practicing allergist and immunologist at Marycliff Allergy Specialists in Spokane. Dr. Jiten Patel is with the Pulmonary Critical Care Center at Rockwood Clinic. And Suzanne Levitch is an advanced practice registered nurse with Marycliff Allergy Specialists. And I want to thank all of you for being here tonight. This is certainly a very hot topic, especially this time of year. So Dr. Kernerman, let's begin with you. Talk about what happens, especially in the spring, when we're talking about pollen and seasonal allergies. What's going on?
So you might have noticed trees are blooming, and that is the pollen that we're seeing right now. So alder, birch, sycamore, these pollens are coming out. And people who are sensitized to that will start to have allergic reactions. So people are having itchy eyes, they're having runny nose, they're starting to sneeze, they're having nasal congestion, they think they have a cold. It's probably allergies.
And how do we know the difference between having the common cold or having an allergy and seeking treatment for that allergy, Dr. Gower?
Well, a common cold causes fever frequently, aches and pains, even if it's not the flu. And hay fever, or allergic rhinitis, really is not caused by hay, and it's not associated with a fever. So usually it's how you feel, other than just being tired or stuffy, drippy nose or itchy eyes. Usually you can tell if you think about it, but most people blame it on viruses, especially if they've not been diagnosed properly as having allergies.
But these can be quite severe. It can really be debilitating for some people. So the severity can go from anywhere from just, feeling a little crummy that day with a little itch in the back of the throat to really putting you down, for a number of days. And so, Dr. Patel, should I seek treatment at that point? Because I can get relief.
I think as you develop a sense of what allergies you've had to as growing up. Sometimes some of these allergies start when you're younger and you've developed a certain acumen. That certainly if you find that your drip is worsening, or you got itchy eyes, or you start developing a runny nose that's uncontrollable with a worsening cough, that perhaps your primary care should be readily available.
And what kind of treatments are we talking about now? What's available?
We're very fortunate today because there are very effective treatments that are available in stores. It's helpful to have someone guide one through the system, but most of the antihistamines that used to be prescription can now be obtained.
The Claritins and those sort of treatments?
Zyrtec, Allegra, these all used to be prescription items, and now for most people they can go in the store. If someone has mild allergies, that might be all they need. An allergy specialist will start to see people who they're missing work. They're really suffering. It's not just, oh, my nose, I'm sneezing. It's, I feel fatigued. I feel wrung out. I sneeze 20 times in a row. Just feeling miserable.
Yeah, and this can also, kids can have problems with this too, Suzanne. And so, how is it different from in children and adults, or does it present pretty much the same?
Children are pretty resilient creatures, and really you can't tell as easily with a child, especially a toddler. Allergies can present as early as a year or so, but a lot of times you'll see the runny nose, the drippy nose, or they'll have atopic dermatitis, and some children go on to have asthma, and most children that have asthma have some allergies.
So there is a relationship between the two, because we want to talk tonight also about that connection with asthma, and we're actually going to meet a woman in a while who has dealt with that all of her life. But what is the connection then, Dr. Gower, between the two?
Well, the fact that allergies cause asthma in a large majority. If you have a child who has asthma, probably 85% of the time they have allergies also, as a trigger factor, as a causative factor of the asthma. If you have an adult with adult onset asthma with no history of allergies as a child, and they're 30 years old, that has a lesser frequency of having allergies, maybe 60-65% of the time. But still, that's a large association, because the IgE allergy antibody that is produced by the body against antigens causes a lot of reactions in the body, causing the itchy eyes, itchy runny nose, stuffy nose, drippy nose, and stuffiness and congestion and phlegm production down in the chest, asthma. And so if this exacerbates up in this area, it tends to make this worse as well. So whenever you see anybody with asthma, one has to consider the possibility of allergies as a trigger factor.
And we asked the question in the open of the program, are we seeing more seasonal allergies or allergies overall, or are they being diagnosed earlier, or can we answer that question even, Dr. Kerneman?
All of the above. I think we're much better at recognizing symptoms and calling them what they are, diagnosing asthma and treating it, diagnosing allergies and treating them. There probably are more allergies. There's probably more recognition of the allergies themselves.
I actually had a coworker, and many of them come up to me and when they found out this was our topic tonight and wanted to present questions to me. One of them said that she has dry eyes as a rule, and then gets the seasonal allergies, but when she tries to treat the dry eyes with drops, it just seems to make the condition worse. Again, is that something that she should seek help from her doctor to try to treat the two presenting problems there that are kind of colliding, I guess, this time of year?
I think there's multiple symptoms when you talk about allergies, with itchy eyes, dry skin, post-nasal drip, cough, chest congestion. There never is just one symptom that presents. You're absolutely right. Most patients complain of multiple symptoms, but when they start impacting your quality of life, you certainly suggest that perhaps we should get some help, or they should get some help.
Okay.
Teresa, let me put one thing on the table that I want to make sure we cover tonight, lest we forget it later on, and that is, it's a multitude of symptoms, but they have to recognize and sometimes put that package together, and patients don't always do that. That is the only real risk I see of having very good over-the-counter medicines, because sometimes people, especially in allergies, most people who have allergies had it as a kid, as Dr. Patel said. So they get used to it. And when they get used to a headache or stuffy nose or mouth breathing or tiredness or not sleeping well or coughing or wheezing, and they're 20 or 30 years of age, that's the way they've been all their life. So sometimes they don't sort that out until it gets really bad and they go to the emergency room, or somebody else tells them that. So self-diagnosis can be a two-edged sword when it comes to that. Mm-hmm. So they're cheating themselves by not really getting optimal care. Again, I agree with Dr. Kerneman. If they are mild or mild-moderate and they diagnose properly, they take the proper medicines, and the medicines work well from over-the-counter sources, I have no problem with that. But there's an awful lot of people that fall in the middle of mild-moderate or moderate to severe or moderate that really are not doing as well as they should, because the patients are not recognizing the significance of the symptoms.
Because maybe mom and dad, when they were children, didn't recognize it?
That's true.
It was
Certainly
just
in
something
my-
that happened every year in the
Right,
spring or something
right.
like that?
They had summer colds, they had spring colds, and as was mentioned, it's probably an allergy. And if you start looking at, I mean, we've all seen patients, and you bring it like, does this occur? Well, every spring I have a cold. You know, I'm home around cats, I get a cold. I mean, you know, pretty soon you start
Yeah.
thinking this is probably allergies.
Yeah.
Or that yearly sinus infection, that's a key too.
Yeah.
Because it can get into the sinuses in that regard also. And Dr. Patel?
I was just going to say, to add to him, there is such a thing as a historic atopic march, where children as a child develop atopic dermatitis, and then as they went into early childhood, adolescence, they develop allergic rhinitis, and then subsequently develop a certain percentage. Ms. Gowers had mentioned asthma, and you'll have that learned patient who knows when they're coughing more, wheezing more, or short of breath, that they should get help. But there's a large number of patients that don't realize that's not normal.
In the same regard, I've had people tell me, well, I didn't have hay fever, seasonal allergies when I was a kid, but as I got older, I started developing those allergies. Can that also be the case, Dr. Kerneman?
I see both children and adults, and one of my favorite scenarios, it's not my favorite scenario, but one of my favorite scenarios is I'll see kids, and they're 5 to 12 years of age, and 50% of allergy or so shows up then. Then I'll see people in their 30s, and they're like, gosh, you know, why am I having allergies? And they'll be a little bit surprised, maybe a little amused, but okay, I can deal with that. And I'll see people in their 50s, and they're pissed. It's like, I'm not supposed to get allergies. How can this be? I mean, isn't that something kids get?
Yeah.
You know, so, and I like to say, I saw a gentleman who was 99 years old. He didn't have allergies before, and I was seeing him for an allergic problem.
That's crazy.
So it really can occur at any age. There's no cutoff.
And I guess that's why it's hard for some people to even recognize the fact that they have allergies, because they never had them before.
That's true, and that does happen. On the other hand, sometimes they had it as a child, and it just got worse with the march that Dr. Patel was talking about. They had progressive symptoms. They're teenagers, and of course, bullets bounce off of teenagers in their own mind. And they get busy, other things take precedence. They get married, they go to the workforce, and they start having sneezing or coughing or wiping their nose, and their co-workers start bringing this to their attention, and they have health insurance then, and they start recognizing that they're different than the other people. They have symptoms. So it's recognized and paid attention to perhaps when they're 20, 30, or 40, but they may have had it all their life. You ask them, did you have asthma? Oh yeah, I almost died 15 times as a kid, but I don't have asthma anymore. Well, if they had asthma before, they still have the genetic tendency to have asthma. They can grow out of the symptoms, or the symptoms can grow worse. And as good detectives as we are, we have to sort of sort that out, and patients will not necessarily volunteer all that information because it didn't seem important to them before.
You know, speaking of that, brings up an excellent point about diagnosing and kind of weeding that all out. What is the process when you have a patient come to you? Because obviously in the Northwest especially, we have many things that can bloom from, you know, the pine pollens and any sort of trees and grasses, and as you mentioned, the molds then coming into play. So what is the process for diagnosing and really nailing that down, I guess, so to speak?
In our office, tomorrow is a big day. We're going to be starting to do pollen counts.
Oh.
So,
and we even see those on the evening newscasts now,
Right.
so people can pay attention.
So we actually know exactly what pollens are out there, and over time, an allergist kind of learns what the topography is as far as pollens in the air, and you kind of fine-tune what you're testing for depending on what you know is going to be out there. And in any allergy office, there's just certain things you know they're going to hit at certain times, give or take a week, and that's what you test for. Because, for example, there's certain things that we don't have here to any big degree, like olive trees. We just don't have them. Someone could be sensitized for that, but olive trees don't do well here, so we don't necessarily just test for people for that. We do have all variety of grasses, and that's a huge allergen here, so we absolutely test for that. We have Russian thistle here, so we definitely test for that. We have birch and alder here, so we definitely test for that.
And how do you test for that?
The most common way that an allergist would test for an allergy is to do what's called an allergy skin test.
So the scratch test, we used to call it, I think?
Used to be, well, I don't call it a
Something
scratch
like
test
that?
'cause
Used to be? Okay.
it seems kind of tyrannical, you know? You don't like to go up to someone and say, yeah, we're going to scratch you up.
I know.
We're going to
having a
torture you.
flashback.
It's a skin test.
It's not called a prick test.
We don't like to call it prick test. It's just, we're going to gently apply to your skin. And really, for most people nowadays, as opposed to when we spoke to our parents, allergy tests might have been far more difficult. Now, I think most would say that, yeah, it's uncomfortable, but it's not terrible. But a skin test would be applied usually to the arm of an adult. On a child, it might be on the thighs. Sometimes one might use the back, depending on how the skin is.
And will you see a reaction immediately then when you do
15 minutes.
that? 15
Traditionally,
minutes.
about 15 minutes is you have your answer. And from there, you have your plan.
It sounds a lot worse than it is. I mean, it's like taking a little needle and pricking the skin. That's what it's called, a prick test.
Just sort of a little irritation there so that...
Right. What you're doing is breaking the surface of the skin, introducing whatever the antigen is, food or environmental antigen, and then if the body has the IgE allergy antibody against that antigen, then it has a reaction, sort of like a little mosquito bite. And we measure that.
Now, I mentioned today being a rainy day. I said, well, the pollen shouldn't be as bad today, but when I mentioned that to you, Suzanne, you said, but that's when the molds can come into play.
The molds can come out.
Talk
yes.
about that.
So molds, most of them live in the soil, although we do have some household molds too, but most of them live in the soil. So when the rain comes down, it kind of washes the tree pollen, which is out right now, down to the ground and just lets it lie on the ground. But the raindrops then, when they hit the ground, the spores from the mold can come up and they're aerosolized.
So people that are allergic to molds then will have difficulty on a
problems.
rainy day.
Correct.
Okay. There's no escaping it.
There's no escaping.
There really is.
Well, and allergies will be tricky too because, for example, tree pollen was out yesterday and the day before, not so much today. Well, there's people who were sensitized through yesterday who are actually having symptoms today.
Well, I was noticing symptoms today, and
that
I'm
might
one
be
of
from
those
what
people that
happened
says I don't have allergies.
But it takes a while. The immunologic pump, it has to be primed, the system does. And that's, you can make the case to handle that by treating it. If you know when your symptoms are going to be in the spring or the summer or the fall, start the treatment a few days or a week or two before that. And the plants are smarter than we are. I mean, they pollinate pretty much on schedule, although with global warming, maybe the seasons are expanding a little bit. So once it's started, it takes as the season progresses, it takes less and less and less to cause more and more symptoms. So there can be a delay.
Get a jump on it then.
That's right.
Get a jump on it.
That's
Let's
right.
bring in our first phone caller this evening. We have Reg calling from Montana. Good evening, Reg.
Good evening.
You have a question for our panel tonight?
I do. When I was in my 20s, 30s, 40s, I had lots of allergies, and my eyes would swell shut. My eye, and I would just drip, and I would get fixed up with the doctor's injections and so on, and try to control this. Also have a severe allergy to sunflower seeds. Do I get over those? Because I don't have near the symptoms anymore as I used to, and I'm in my 70s.
Dr. Patel?
I think my allergist would probably perhaps have better because...
Well, that's one of the good things about getting older. You tend to get less allergic, but not always, as Dr. Kerneman said earlier. However, you get cancer, kidney stones, and heart attacks and so on as you get older, so it's a wash. But the immune system does change, and that's one of the good things to look forward to. And I congratulate you in making your 70s. I'm not there yet, but close.
So again, it's just sort of that process. You can,
It's a
something you
process.
may have had as a kid, you may not have when you're in your 70s.
And it happens with asthma as well as the allergies. And this can happen to food allergies as well. I mean, some people will go 50 years and never have a problem, then they can develop. That's unusual, but it can happen. Food allergies in children are a lot more common, and then they tend to outgrow most of them, although peanuts and tree nuts and shrimp, they tend not to, but they can. So you just have to listen to the body and then figure out, if you can, by yourself, your family doctor, your allergist, as to what the cause is, and if you're getting better, celebrate it. I congratulate you.
Okay, let's bring Sherry in from Spokane. Good evening, Sherry.
Hello.
You have a question for the panel.
Yes, I do. I went to an allergist here in Spokane and got tested. I'm allergic to every blade of grass and tree in the whole area. And I tried to go for allergy shots, and I also have really severe arthritis. And every time I got an allergy shot, it went right into my joints. And I've tried all the antihistamines, and I can only take Zyrtec and Benadryl. That's about it. And they're getting worse year after year, and I'm getting sinus infections. What's new? What's on the horizon? The allergy shots are not for me. And it runs in my family. All my kids are just bombed.
All right, Sherry, excellent question. Who would like to answer Sherry's question? If there's any relief for her.
Yeah, that's a drag with the rheumatoid arthritis being made worse with the allergy shots.
Do you know of anything new that she could try, she should talk to her doctor about?
I would assume that there were some attempts at other non-antihistamine medicines, maybe leukotriene antagonists, maybe intranasal corticosteroid sprays. I don't know if we want to talk about anti-IgE antibodies, which is a type of injection not approved for that, but it might be worth her going back to her allergist and just kind of laying this all out on the table and saying, you know, what else? There's got to be something. Yeah.
There's also a new form of treatment called slit or sublingual therapy, tablets, and 2 of them were just approved specifically for grass within this month,
which she
April
mentioned.
1
Yeah.
and April 10 or something like that. So that might work. It's a daily therapy rather than a weekly or monthly therapy, such as a subcutaneous therapy. Similar mechanisms, but different area. I mean, you're using the gastrointestinal system, the immune system, to invoke the immune response instead of through the skin and the subcutaneous tissue. So that's a consideration. In the old days, that was a relative contraindication. At least it was a consideration for not putting people on shots if they had lupus or some active autoimmune disease. The studies that I'm aware of the last few years have sort of disproven that. But sometimes when there's smoke, there's fire, and if it's not statistically important, doesn't mean it's not for any one individual. So if that's the association, then I think Dr. Kerneman's suggestions, trying again. If the symptoms are bad enough, keep trying again. There's newer medicines, alternative medicines, and it would be worth a trial.
Okay.
I would add, though, rheumatoid arthritis actually complicates or confounds what's going on here. It is, like Dr. Gower was saying, that it's an autoimmune process, so there's certainly numerous pulmonary manifestations of rheumatoid, anything from polyps to tracheal polyps to wheezing and reactive airways that you can get. And so although she's positive for multiple allergies, some of her concert of symptoms may affect her window to her lungs, which is her sinuses and her lungs. So I think perhaps a discussion with a rheumatologist as well may facilitate matters.
Let's bring Carrie in with a phone call from Chatteroy. Good evening, Carrie.
Good evening. I think I have a question probably for Dr. Kerneman. I have a family member who has problems with aspirin. When they take an aspirin product, they have problems with their asthma. Is there any treatments available that would be helpful in that situation? Because they're kind of getting to an age where they need some sort of a non-steroidal or some sort of an anti-inflammatory, and all those medicines seem to cause more issues with their breathing.
Very good. Thank you, Carrie. Dr. Kerneman.
So there's some people that have asthma that is triggered by allergies. Some people it's by viruses. Some people do a funny thing where if they take aspirin or a non-steroidal anti-inflammatory drug, kind of triggers their asthma, and it promotes sinus trouble and polyps and things like that. There is something where you can be desensitized for the aspirin, and that's called aspirin exacerbated respiratory disease. And that is something that we do here in Spokane. So it's something that in the literature they report it a lot. I don't think it's as common as that, but there is treatment. So that would be worth discussing with the doctor.
Okay. You know, we've brought up the topic of asthma a few times this evening already, so I want to talk more about asthma now. And in some cases, if not treated properly, asthma can be life-threatening. But we met a woman who showed us that it doesn't have to be life-altering. Jogging through her Coeur d'Alene neighborhood, Teresa DeWitt feels her lungs fill with air and listens to the steady rhythm of her own breathing. And she doesn't take any of it for granted. The 50-year-old flight attendant leads an active, athletic life that must have seemed impossible when she was growing up with asthma.
It was really limiting. I was a kid who always liked to go out and play. I wasn't the kid who stayed inside. I was outside, always outside. I had a million scars, knees and hips from playing outside. And I couldn't all the time because I had to come in and sit on the couch when I couldn't breathe. When I got into my teens, my asthma really spiked. I was in and out of the emergency room all the time.
What sets her off?
It's molds and mildews, animals, and then I just have kind of a baseline unhappy lung.
When she was a teenager, Teresa's frequent hospital visits were replaced by home therapies with the introduction of the drug albuterol. It's a bronchodilator that relaxes muscles in the airways and increases airflow to the lungs.
If I know I'm going to go exercise, I'll always take my albuterol inhaler just to puff before I go, and then I'm fine. I can go run Bloomsday or run a half marathon, but sometimes I'll keep that inhaler with me just in case.
Teresa controls her asthma with a daily dose of corticosteroid, a medicine that prevents lung inflammation. She advises other asthmatics to keep a strict therapy routine.
Take your maintenance meds. Who wants to take a medicine when you're not feeling sick? But that's the point, is it keeps you from feeling sick. And working with your doctor to find the lowest dose you can use to maintain an even balance in your life.
This is advice she shares with her family.
I have 3 children. My oldest son doesn't have any asthma. My 2 daughters, however, do. Very similar to mine, where they're allergic to pets. They also have exercise-induced asthma.
With a mom who runs a half marathon, travels internationally, and even plays the flute, Teresa's girls know their asthma doesn't need to be an obstacle.
There are things that you can do to still have a wonderful, normal, active, vibrant life and still have asthma. I don't consider myself, I'm an asthmatic. I don't wear it like a label. It's something that I deal with, it's something that I have, but it isn't something that keeps me from anything.
Saw you nodding quite a bit. She has a great attitude.
I wasn't sleeping.
Not nodding off, just nodding in agreement with Teresa, because she really does have a great attitude. She knows how to manage her asthma, and so many things coming into play there. She mentioned some allergic triggers also.
Well, asthma has been my favorite disease to treat. I don't have asthma for all my career in medicine. And one of the reasons, it's a potentially fatal disease, but it's also an extremely treatable disease. I can't make the points as well as she did. Take your controllers. If you have a disease that's constant, like hypertension or asthma or whatever, you need a controller, a constant medicine to raise the threshold and control the disease. She spoke very well of that issue. If you don't do that, you can get involved in triggers from allergies or aspirin or infections, and I've seen people die from that, and I've seen many more lives impaired by that, the quality of life impaired. And so it's so nice for us to see patients like Ms. DeWitt. And that's what we live for, to help patients like that. There's a lot of diseases we can diagnose but not treat, but asthma is a very controllable disease. Even the more severe asthmatics can lead a really very good life. If they're diagnosed properly, they do all the right things. They don't sleep with 13 cats if they're allergic to cats. They don't smoke, and they take their medication. So it was heartening to me. That's why I was nodding. It's a very good testimonial.
Mm-hmm. She also stays extremely physically fit. We see that she's a runner. How important is that in allergies or asthma to make sure that you're eating properly and staying physically fit?
Well, one of the things that I like that she said, and I try to be very careful with my verbal hygiene when I talk to someone who has asthma, I say, you're someone who has asthma. You're not asthmatic. In other words, the asthma doesn't define who I am. I just happen to be someone who has asthma, and I have to deal with this. This is just something that's on my plate. So one of the things that you can do is take your medicines. Another thing you can do is take care of your body. Exercising the lungs just seems obvious, but yeah, I mean, being as absolutely into life as one can be.
Because there was a time many years ago where people with asthma were told not to be physically fit or to overexert, I guess, that wasn't what you were supposed to do. It's completely contrary to what she does.
I agree with Dr. Gowan, I'm sure Dr. Patel and Suzanne, in that in our practice lifetime, one of the things that's been hugely gratifying is the treatment of asthma. Asthma used to be something where you would be hospitalized, you would be in the emergency room, you would be constantly using quick-acting medicines, you would be sick, you would be missing out, you would be sidelined. Whereas today, most people with intermittent or mild or moderate asthma or even severe asthma are fully functional. And that's because of all these advances in just understanding how to treat it.
And I also think the patient's understanding the disease. I know that all four of us around the table believe very much in patient education. In addition to taking the medicines, avoiding the trigger factors, and taking care of the body, they have to understand the disease. And we have websites, we give them literature, we give them articles, we educate them on what the disease process is, how to handle it, how to live with it. And the time to not run a marathon is after you've had a bad infection, it's gone into your chest, and some infections go into the chest and trigger the asthma much more than others. It may be time to fold it and not run that time. And so knowing their body, knowing what their limits are, and knowing what they're capable of is very important, I think, as well. So the education aspect is extremely important, I think.
And with that said also, there are sports asthmatics, right. People who are, when they do exert themselves, will have asthma. What is the difference between the two?
Well, I think there's different definitions of asthma. It's a reactive airway. It's where your airways close down, and there's certain precipitating factors. I think for her, what's wonderful about her, I want to step back, but most people innately will stop working or doing anything when they're short of breath. The fact this lady is active, uses preventatively a puff of her Ventolin for exercise-induced bronchoconstriction is a wonderful obstacle she's overcome. So when do you decide not to? Well, if your symptoms are worsening, she's obviously cognizant. She has a family history. It's a learned behavior. Her daughters are going to see this. If they develop asthma later in age, they'll be make sure they'll avoid their allergies and certain precipitating factors, avoiding people with perfumes, or if there's cats or dogs that mom was allergic to, chances are they won't grow up in a household with a cat or a dog because they have a history of reactive airways or asthma. So I think it's important that patients become cognizant of what triggers,
play a role in their
asthma or their symptoms.
Absolutely.
And then understanding what their maintenance therapy is. There's lots of medications on the market in oral form, inhaled form. That's in the armamentarium of treatment for asthma. Her maintenance, the key word she used, maintenance. That's very important. I think you'll all add to that. There's one medicine might not work for her, might work well for another patient, but trial and error in part plays a big role.
Absolutely.
And with respect to the exercise, as Dr. Patel said, and just to extend that a little bit, not everybody responds to the same trigger factors the same way, and exercise is the sole trigger factor for some people who don't have chronic asthma. They just have exercise-induced bronchospasm.
And we see that in children all too.
Right.
Yeah. They'll hit the soccer field and have an episode.
And coughing tends to be the first manifestation of that. Little Johnny is running, and every time he runs or plays, he coughs. That sometimes is the first manifestation of asthma symptomatology. But the exercise itself can be a trigger factor for some people more than others. And yet people who say, when I ask them, do you have asthma? No, I don't have asthma, I just have exercise-induced asthma. The reality is statistic, and that may be true, but people don't want to have asthma, and I don't blame them. But they may have just bronchospasm induced by exercise, but most of them, about 80, 90% of exercise-induced bronchospasm is really chronic asthma, just made worse by exercise. Right. So it leads to what Ms. DeWitt was saying. Do all your right things, avoid the triggers, take your medicines, raise the threshold, do what you want, and live life.
Okay. Yeah. We have a number of phone calls we want to try and get to. Vivian from Spokane. Good evening, Vivian.
Good evening. How's everyone tonight?
We are wonderful.
Thank you.
I have an odd question. I'm 75. For 57 years, I was a very, very heavy smoker, but I have not smoked for a year and a half now, and my allergies are worse than they have ever been. Would the fact that I'm not smoking make them seem more important than they were when I was smoking?
First of all, congratulations on stopping smoking. Obviously, she's gone through a big change after smoking for so many years. So what may be going on with Vivian and the allergies presenting now that she has stopped smoking?
Well, I think the residual effects of tobacco are profound. Tobacco itself and smoke inhalants and the other 2,200 constituents leads to chronic airway inflammation. So albeit it's phenomenal that she's quit, she's overcome a huge obstacle. The chronic inflammatory response from tobacco and the number of years she smoked has an effect on her daily symptoms still. And so what that tells us that perhaps she needs better control of her chronic inflammation in her airways. So perhaps if she's still having symptoms, an inhaler, a steroid, or different agents that are longer acting Ventolin forms that will hopefully manage her chronic cough or wheeze or shortness of breath she's describing.
One thing that Suzanne and I have noticed, I think, in our experience is that when people have stopped smoking, they become more alive, and it goes to the points that Dr. Patel was making. And some symptoms that they might have had, they didn't know they had because of the smoke. And when they quit smoking, they taste better, they smell better, they're alive more. Actually, the chest sometimes produces more phlegm, and people say, I never was this bad when I was smoking, but I'm a lot worse now in my chest. But the same thing applies up in the nose and the sinuses. Things start sort of discharging, cleaning the lungs out, if you will, and they recognize that.
So she could be recognizing those symptoms more now that
typically,
she's stopped.
from the lungs at least, that's a very good thing to get that stuff out of there.
Yeah.
In part, with active tobacco smoke, there's certain hair follicles that propel and elevate up, and they're stunned when you're an active smoker. So as they start to recharge and regenerate,
sort of numb.
You start to slough some of that old material, and you start having those follicles and hair follicles that cause mucus to migrate up, and that's why she may have increasing cough or sputum production with that cough.
Okay, let's bring in Betty from Coeur d'Alene. Good evening, Betty.
Hi.
You have a question for the panel tonight.
I do. I have angioedema. That's an allergy, and I'm very allergic to fresh fruits and some medications. And if I eat fresh fruits, my mouth swells. I have to do an EpiPen. Benadryl sometimes helps. Now, and also I'm allergic to some prescription medications. Is there any prevention or treatment that can be done to help these allergies?
Are you currently on any treatment, Betty?
Just when it happens, and you never know.
Okay, so you're looking for something preventative.
Yes.
I can address that. Is there any family history of angioedema? Anybody else, brothers, sisters, parents have angioedema?
My two daughters.
Okay, well, there's a syndrome, very rare, 6,000, 7,000, 8,000 people in this country who have hereditary angioedema. And it can start any time. Once it occurs, it's autosomal dominant. So usually there's a family history, but it doesn't necessarily have to be your parents. It can be you and then your siblings. So that's a possibility. For that, we have lots of new treatments. For most angioedema or swelling, which is sort of like big hives, if you will, deeper vessel involvement of leaky vessels, that's what we call angioedema of the garden variety type, and that can be from foods and drugs and other things. And the only real treatment for that I know of is avoidance, identification, avoidance, and knowing cross-reactivities of foods and medications, and then taking antihistamines and other kinds of medicines like that to suppress the inflammatory response.
It sounds like, though, in some cases she doesn't know that it's going to happen until
But she may be exposed to some things that cross-reacted with things that she knows she's sensitive to.
Okay.
So.
Dr. Kerneman?
I suppose I think she should be visiting with someone, helping her to figure that out, because I was thinking, well, fresh fruits and vegetables, there's a kind of an odd variation on food allergy called oral allergy syndrome, where you have people that react to fresh fruits and vegetables to certain pollens that they botanically cross-react to, which is a way different thing than angioedema. It can cause angioedema, but it's kind of a different beast entirely. So if not having visited an allergist before, then please do so now.
Okay, very good. Jerry from Otis Orchards with a phone call this evening. Good evening, Jerry.
Good evening. How are you?
Very well.
I've been enjoying your program, and just wanted to mention you had spoken of a worker there at the station that has had dry eyes, and when she took drops, apparently it didn't help. I've had dry eyes for a number of years, and I had a doctor actually help me with that, an MD, who said if I would increase the iodine production in my diet, the iodine intake in my diet, that it would help the dry eyes. And he put me on a little program where I put it in fruit juice and took it each day. And I can honestly say it certainly did increase the tear production. And I was just wondering if the doctors might have some thoughts on that, if that's a method they ever use, or if it just happened to be this particular physician.
And Jerry, do you find that you have the dry eyes particularly this time of year, or is it year-round?
Year-round.
Year-round.
With me, so it's not actually necessarily,
allergy-related?
Allergy-related, but it certainly does, and certainly does increase the tear production. He put me on it a pretty heavy dosage for a period of time, and then tapered it off, and it did work.
Okay. Suzanne, is that something you've ever heard of?
I think that's a better question for our allergist friends, because I'm not familiar with that at all.
No, I'm glad he's better. As we all age, we tend to get dry skin, dry eyes, dry mouth, and so on. There's autoimmune diseases that are associated with that too. Hearing none from Jerry, I don't associate that, but I don't know how the mechanism of iodine in the juices would help. Glad it did. It could have been circumstantial, relatively safe, without harms that I understand, but I don't understand the mechanism there.
Interesting though, and it seems to work for him, so that's good to hear, very good to hear, and I'll pass that along to my coworker also. Something we've just barely touched on, and we've gotten into the food allergies, but certainly peanut allergies have become so prevalent in the last few years, especially among children, deadly in some cases, and in some cases, children can't even be near a peanut or a product that has peanuts in it. What are we seeing with peanut allergies that we didn't see when I was a child? Dr. Gower?
Well, it's recognized more, and it's more common as well, I think. In this country, we basically roast the peanuts and the nuts more than, say, in China. In Thailand, they broil theirs, I think. And so there's a difference in the antigenicity or the allergenicity of the product. So we're seeing that more and more. It's a problem, especially on airplanes and schools and so on. Again, the hallmark treatment of any allergy is to identify and avoid. The nice thing about peanut allergy, if there's any good thing about it, is that there's some oral desensitization programs that have been evolving over the last few years with success. It's still not standard of practice. It's not licensed for that in this country because of the risks of that, but it works, and we will see that hopefully in my lifetime. And I think that what you do is, for those people who cannot avoid, then you put them on the therapy to desensitize them, to help protect them and give them quality of life and mobility of movement.
So it's a process of slowly introducing peanuts?
Same thing with the slit oral desensitization and the subcutaneous desensitization. What we're doing with desensitization of any sort is and like the aspirin desensitization per Dr. Kerneman, is fooling the body into accepting it as not foreign, and it works. Allergy shots have been used for 100 years. The oral tablets have been used for years in Europe. Now they're licensed in this country. Aspirin desensitization has been used for 20 years, 30 years in this country. And the peanut desensitization has been evolving for 20 years at least. So I think that we'll see that happen in the near future as it's perfected, which will be life-saving for some people, because some people cannot avoid, and they're so super sensitive that just little bits will set them off. And I think that's the remarkable thing about this field. It's not just a stuffy nose, it's anaphylaxis and it's death, not just from asthma, but from foods and
the
medications.
The throat can start to close, it can become deadly.
Yes, and bee stings as well. So that's called anaphylaxis, and that's what peanuts do and nuts do. They cause anaphylaxis in patients.
And those patients will carry an EpiPen with them. They'll be quite aware of it.
We hope they will carry their
unless
EpiPen.
they don't know they have it.
Right.
Correct.
And then it can become quite dangerous.
Right.
Let's take another phone call. Millie from Fairchild Air Force Base. Good evening.
Good evening. I'm sorry for my my voice, but I have fallen victim to this contagious gombu, as I call it, that's been going around. I'd like to ask what I should do. I don't want to go to an emergency room because it hangs on for a week. My throat's on fire, my chest is on fire, and I'm exhausted. So what should I do?
And it just started?
I've had it for 3 days, and I still have to work. And I got it from my client. I'm a caregiver.
Okay, so it's not an allergy.
No, it is not.
Okay, so do you know if there's a trigger, something that causes you to get this every year?
I don't get it every year. I have gotten it from my client, and I've had another friend that's had it. They've been down for a week, and I just don't know if I should go to my allergist or should I go to the doctor.
Okay.
Go to your doctor.
A visit to the primary care is warranted, definitely.
She sounds miserable.
Yeah, she does. She sounds like she caught something, so a virus.
So probably not a seasonal allergy.
Probably not a seasonal allergy.
And there is some crud going around right now,
There
too.
is.
So we know it's sort of all mixed in, too, with the seasonal allergies right
Certainly
now.
will trigger, viruses can trigger allergies and her postnasal drip and congestion.
There they go colliding again.
Yeah.
This time of year. So much fun.
A matchstick.
You mentioned also bees. A number of years ago, my own father, who had had a number of bee stings, was stung by a bee. I was a teenager at the time. The throat started to close. I was home with him, had no idea what was going on. He didn't even recognize what was going on. And again, he had been stung a number of times, and this one particular time had a bad reaction. How common is that, sort of out of the blue, or is it a different variety of a species of a bee that you're getting stung by? Because I don't think it's happened to him since.
This is another area where an allergist can be extremely helpful. Someone who's had a systemic reaction, defined by losing their blood pressure, having anaphylaxis, having swelling in the throat,
and it happens so fast.
Something that happens that fast. There's treatment. People that are specifically allergic to specific bees, for example, a yellow jacket, they can be tested for it and they can be desensitized for that. And in our world of allergy, that's a very satisfying treatment because it is effective and it can prevent people from going into a systemic type reaction in the future. So if someone has that, it's really worthwhile kind of exploring and not just accepting that, okay, I'm going to sit inside in the summer and I'm not going to go to picnics and I'm going to have my EpiPen with me all the time. You know, that there are things you can actually do.
That's very good to know.
We've all seen that, and we've seen the grandmother who sits behind the dining room door for 20, 30 years watching her kids or grandkids out on the patio having parties, because if she gets stung again, she has a 50, 60, 70% chance of dying. And the immunotherapy to venoms that Dr. Kerman brings up, that's about 97% effective. That's about as good as penicillin for strep throat. If you take the shots, once you get on it, get controlled, it gives versatility and comfort and quality of life. So again, you have to recognize, are you bad enough to go see somebody about it? And this is where the discipline of assessing the severity of the problem, like your father had, because they never had it before, and after it's all over, if they survive, they feel fine. So they think
he's
the
never
problems,
sought treatment, by the way.
Well, I didn't know that, but I assumed that.
Yeah.
A lot of people don't. And when we take the histories, at least allergy immunology, we ask venom sensitivity. Well, not anymore. I almost died. I went unconscious. I lost my blood pressure, but I'm okay now.
Just fine.
Have you been stung since? No. But the numbers show that if they get stung again by the same or similar critter, they have a 40 to 70% chance of having same, worse, or dead. Yeah. And they don't all carry their EpiPen or their epinephrine, AviQ, or something,
Adrenoclick.
Adrenoclick. I mean, there's 3 or 4 products that have epinephrine on the market at this point. It's tough to carry that stuff with you all the time. So the shots give the versatility with great efficacy.
Okay.
Something that I find fascinating is I'll see someone who truly is allergic to bees, and we do testing and we go through the explanation of going on desensitization, and I say, I didn't know this was available. Like, it's something that's a unique treatment, whereas this has been available for 100 years, perfected maybe 40 years ago when we went to specific venoms and better techniques of diagnosing and treating. But still, this is something where if ever you could get the word out to someone, you would really hope that someone who is anaphylactically allergic to bee stings talks to someone, a healthcare professional, about it, because there are things that can be done.
Well, this is an excellent platform for that, and a lot of people listening tonight are having light bulb moments, no doubt, when it comes to those reactions. Let's bring in Jim from East Wenatchee with a phone call this evening. Good evening, Jim.
Good evening. Thank you so much for taking my call, and thank you for your wonderful program and all your participants there. Very interesting. I know you started out there with asthma, and it triggers a question. I was wondering, can doctors tell if a person has asthma as well as pulmonary fibrosis? I've been diagnosed with pulmonary fibrosis, but I wondered if I have asthma too, because my mother had it. In fact, she died of it. She went into a coma, and a friend of mine has asthma, and he tells me different things he does, like hot coffee, to calm down his asthma, and I've tried that, and it helps. I take a homeopathic medication for asthma sometimes, and that seems to help too. So can you distinguish between the two, or are they all lumped together, or can doctors tell if I have asthma too?
Dr. Patel.
It's a complicated issue, but when he describes pulmonary fibrosis, it's a disease of the infrastructure of your lung.
Okay.
So if you imagine a wall with paint, behind the paint, gyprock, behind the gyprock, 4x4s every 16 inches, and the insulation. Pulmonary fibrosis is a disease of the infrastructure, the framework, the 4x4s. Asthma is somewhat the endobronchial airway issue. You can certainly have asthma growing up and it be controlled and it unfolds itself. Pulmonary fibrosis itself is a disease that's an umbrella, and under that umbrella is pulmonary fibrosis due to an autoimmune disorder. It could be idiopathic, it could be related to smoking. You can get fibrosis. It could be just related to some medication or drug. So you certainly can differentiate between pulmonary fibrosis and asthma, as pulmonary fibrosis typically presents with shortness of breath and a non-productive cough. Asthma, typically a symptomology of nocturnal cough, wheezing with shortness of breath, relieved by inhalers, whereas pulmonary fibrosis, your shortness of breath typically isn't relieved by an inhaler.
So the two need to be treated independently of each other?
Or monitored independently. But, you know, patients, they vary, you know, you don't have just one thing. Pulmonary fibrosis, depending on the type, if he has tobacco-related pulmonary fibrosis called respiratory bronchiolitis, interstitial lung problems. Well, it's part of the treatment for that fibrosis that occurs from that is stop smoking, as well as inhalers. So there's some overlap in a certain type of pulmonary fibroses.
So certainly a discussion he needs to have with his doctor.
But in addition to that, I think the way we make that assessment is the little gray cells, like Hercule Poirot says, use the little gray cells. But you have to know something, have the history, think about it, but then you have to test. And I don't think we've discussed it yet tonight. The pulmonary function test is the way you really make the diagnosis, or at least confirm the diagnosis of asthma. And I see so many patients who are on bronchodilators or asthma medicines, controllers, and they've never in their life had a pulmonary function test. And the example I give to them is, if you have high blood pressure, would you start blood pressure medicines? If you have diabetes, how do I know what your blood sugar is if I don't measure it? We don't know what your lung function is unless we measure it.
But those are prescribed medications, so are doctors just prescribing the medications
they
without
make the
test?
diagnosis of asthma on a history and a physical, but they don't do the pulmonary function test many times. And that's not really what they should do. You can't really make the diagnosis adequately, at least with pulmonary fibrosis, unless you do a listen, history, your physical, chest x-ray, and then maybe a thin CT, thin cut CT and so on, or biopsy. There's different ways to assess it. You go down the line. But a pulmonary function test and a chest x-ray, if a person has symptoms that are requiring medications, I think not at all unwarranted.
Absolutely. And to differentiate, the obvious, asthma tends to be an obstructive problem on lung function, whereas pulmonary fibrosis tends to be a restrictive problem. To get a little idea, when you breathe in, that's an active process. Breathing out is a passive process. Pulmonary fibrosis causes a limitation in breathing in, whereas asthma is an issue with breathing out. So there's several caveats, but he's absolutely right about the history and physical examination.
Just one additional point, the asthma can be so dramatically bad and fatal. Usually it's not, but can be. Pulmonary fibrosis tends to be more insidious, gradual, progressive, and I've seen people way advanced in pulmonary fibrosis when they could have, should have, would have been diagnosed 5, 10, 20 years ago. But no chest x-ray was done. I've also seen patients with pulmonary fibrosis that have had a chest x-ray every year, read as normal, and they weren't normal. So it takes multiple evaluations and several people sometimes looking at the same picture to come up with the right answer.
Okay, certainly Jim has a lot to discuss with his doctor or doctors. We are coming toward the end of the program, and so I want to get some final thoughts from each of you, and I can't believe an hour has already passed, but certainly I think one of the things I'm taking away from tonight's show is that you don't have to suffer if you have allergies or asthma. And Dr. Patel, some final thoughts.
I think asthma is a controllable disease. You have to be cognizant of your symptoms. As you've grown up with it, you certainly need to address and avoid those precipitating factors. I think maintenance therapy is an important part. Avoidance is a big part. And then moving forward, avoid those individuals who smoke and don't smoke.
Good advice.
It's one of the most common reasons for why asthma exacerbates, I feel.
Dr. Gower.
Yeah. Well, I think you summarized it, and that is patients should not cheat themselves. They should not suffer unnecessarily. Dr. Kerneman addressed this earlier. If you have mild allergies, you treat it with avoidance, you treat it with mild, safe, over-the-counter medicines. I have no problem. I don't need to see it in the office. But the majority of patients, and there's 25, 40 million patients with allergies, 25 million with asthma, many of them are not well enough controlled because they don't ask enough of themselves, and they cheat themselves, I think, of quality of life. They shouldn't do that.
Demand more.
Demand more.
Absolutely. Dr. Kerneman.
With regard to allergies, I think that in a way, I don't think we've been better at diagnosing or better at treating than we are now. There's so many things that can be done, so many things people can do to avail themselves to, and it's only going to get better. I tell people, just talking about peanut again, who have bad peanut allergy, okay, you might not outgrow it, but how do I know in 5 or 10 years we might not have immunotherapy for that?
Right.
You know, so there's just really amazing things. 50 years ago, if you had told someone, yeah, you just use this inhaler every day and then you'll go running half marathons, they would have been like, yeah, whatever. You know?
Absolutely. And Suzanne?
If you have allergies and they're not being well taken care of by the over-the-counter or by avoidance, come in, see us. We can help you diagnose, help you avoid, and help you treat.
And help you live a better life.
Correct.
Absolutely. I want to thank the panel so much this evening. A great discussion. Unfortunately, that will do it for this show. But before we go, we'd like to thank the sponsors of tonight's edition of Health Matters, Providence Healthcare, WSU Spokane, and Hollister Steer Allergy. We're back on May 15th when our topic will be brain development. Until then, thank you for watching. I'm Teresa Lukens. Good night.
Health Matters is made possible by viewers like you, the friends of KSPS, and by the following.
I really liked the idea of being part of Providence, where if I have a question, if there's something that I'm concerned about, I can always call a specialist. I'm Dr. Anna Barber, and I chose Providence because here I can help children thrive and reach their highest potential.
If you read Providence's mission statement, it's all about delivering quality care to the patient at all times. I'm Dr. Peter Rinaldi, and I chose Providence because they put the doctor-patient relationship first.
Find your doctor online at phc.org.
Health Matters is also brought to you by Hollister Steer Allergy. improving quality of life for allergy sufferers since 1921. Washington State University Spokane, studying the feasibility of a state-funded medical school on the WSU Spokane Health Sciences campus. More at medicine.wsu.edu.